Hi there. How are you?
Good. It's good to be with everyone today.
Yeah, it's so great to have you. Now that we're both on video, we'll officially launch. So I just want to share a hello and welcome to everybody to our What's Up Doc Facebook Live session. My name is Kristen Whedon, and I serve as president of the United Porphyrias Association. We're so glad for the people that are joining and also for the people that have sent questions in advance of our Facebook Live. We are so lucky to have Dr. Amy Dickey with us today. Dr. Amy is a Porphyria expert at Massachusetts General Hospital in Boston. Dr. Dickey, as well as her co-founder of the Porphyria Clinic at Mass Gen, Dr. Rebecca Karp-Leaf, started a Porphyria clinic several years ago and are doing amazing work. So we're thrilled to have you here today, Amy, to answer our live questions. But before we dive into some of these questions, I gave a slight introduction, but how about you introduce yourself a little bit further?
Sure. Hi, everyone. I'm Amy. It's so great to be with everyone. As was mentioned, I'm a doctor at Mass General Hospital, Harvard Medical School in Boston, and I started a Porphyria clinic with Dr. Rebecca Karp there in about 2020, 2019, 2020, started a clinic, and we've seen over almost 150 porphyria patients of various types in the clinic since we've started. And it's been so meaningful for me. I have EPP myself, and so the porphyria journey is a personal one for me as well. And I have been doing research on all the different types of porphyria, acute porphyria, EPP in particular, and it's been a really meaningful process, and I'm happy to answer any of your questions today. And we're a satellite site of the Porphyrias Consortium. We do various group research projects with the Porphyrias Consortium, a group of doctors in the U.S. studying porphyria. And for all of our research studies, the Kristen Whedon and the United Porphyrias Association has been so key in helping us find patients for our studies. And it's teamwork between patient advocacy groups, doctors, patients, to find new treatments for patients and to understand the disease. So thank you for all of you for your contributions to some of those research projects. So it's good to be with all of you today.
Great. Thank you for that. So we have the time, and we do have up to an hour of Amy's time today, and we will dive right into questions. So here's how this is going to work. Everybody that's watching, please put your questions into the chat, and I have a list of the questions, and I'm going to read them aloud to Dr. Dickey, and she will give a response. We are going to get to as many questions as we can. If for some reason we are not able to answer your question today, or if Amy needs to do some research or ask another physician, we will follow up and get back to you. So that is our commitment to you. So you ready to get going, Amy?
Yes, ready.
All right. So the first question is this, and this is related to acute hepatic porphyria. And the question is, have elevated ferritin levels been associated with givosiran?
That's a good question. So ferritin is essentially a marker of iron status in the body, but it also is elevated in other situations, like if there's increased inflammation in the body. So it doesn't always mean that iron is elevated. Sometimes it means there's some other chronic condition that's causing inflammation. In acute porphyria, patients getting hemin can have very elevated ferritin because there's iron in the ferritin, causing the ferritin level to go up, especially right after treatment. With givosiran, there haven't been reports of ferritin going up directly from givosiran. Givosiran doesn't have iron in it, but there may be situations where patients with AIP could have some other inflammation in their body that could be causing the ferritin to go up, potentially indirectly, but there shouldn't be a direct increase from ferritin due to givosiran, but it could be due to other treatments for AIP or to some other chronic inflammation.
Okay, great, thank you. And if there's any follow-up questions, you can put them in the chat as well, friends. All right, next question. Also an acute porphyria, an AIP patient. What are the recommended treatment options for hemochromatosis in AIP patients, as phlebotomy resulted in attacks for this particular person?
That's a good question. So hemochromatosis is essentially a genetic condition that leads to elevated levels of iron in the body. And with attacks of porphyria, anything that will make the body make more heme could potentially lead to attacks. Basically phlebotomy is like taking out large amounts of blood to decrease the iron, and I could imagine that might lead to attacks in some patients. For phlebotomy, sometimes very, very small amounts of phlebotomy over time can be used to decrease iron. So I know every situation is very different. So a lot of the treatments have to be personalized, but something like that to phlebotomize small amounts might be useful. There's also other medications called chelators that can essentially bind the iron to help get rid of it. And those types of medications may be possible to help decrease the iron, but wouldn't be expected to induce more heme synthesis as much as phlebotomy might. So I would, depending on the situation, chelators can have some effects on the kidney or other side effects, so it may not be available for every patient, but I would consider that as an alternative treatment for people who can't get phlebotomy.
Great, thank you. Okay, let's move on to the next question. Amy, what kind of doctor or doctor specialty helps manage EPP?
Oh, that's a good question. So with the porphyrias and EPP, it affects many different organ systems. There's Porphyria experts in the US who are liver doctors, hematologists, dermatologists, neurologists, geneticists. I'm actually a pulmonary critical care doctor, essentially an ICU doctor, and there can be ICU complications of porphyria. Unfortunately, there's not any specialty that learns very much about porphyria in the official training of their specialty. So generally, any porphyria expert has to do more individualized training of porphyria with porphyria experts. In the Porphyrias consortium, some of the junior doctors are often paired with more senior doctors to get more of that individualized training, because there really isn't any formal training to speak of in most specialties. For EPP, it affects the skin, so some patients are followed by dermatologists. However, the main things that need to be followed are often liver function and protoporphyrin and iron studies, which generally aren't labs that dermatologists will typically follow. Generally, to follow those labs, it is recommended for people to be seen at a porphyria center with people with more expertise in porphyria, but also primary care doctors can follow those labs as well if there's not any liver problems already and other issues. So so there are a variety of different specialties, but unfortunately no specialty has very much direct training in it. So generally porphyria specialists would know more about it, but we do have porphyria EPP related guidelines that have been published recently. So if you do have a doctor who's interested or willing to follow those labs and help manage the porphyria side of EPP, those publications about management of EPP and also management of a separate publication on management of liver failure in EPP could be helpful. So you can reach out to myself or Kristen to give you that publication that could be provided to your doctors.
Great. And of those publications for the patient community who aren't medically trained, we also have plain language or patient-friendly versions of those summaries on our website, porphyria.org. So thank you for mentioning those. And we're also turning those into a resource for our patient community. So, okay, so the next question, there's two questions actually that are related to sun creams or sunscreens. The first question, and I'm gonna say both of them so you can speak to both together. The first question is, are there any recommendations for sun creams? And then the follow-up of that is someone with EPP who's 42, and they say, I have always said sun cream makes my reaction worse and burns much more. I was wondering if other people have that experience. So two-part question, recommendation on sunscreens, and does it make things worse or better?
That's a good question. In terms of the benefit of sunscreens or which type of sunscreen in patients, there haven't been very good studies on the topic. So in EPP, we're sensitive to blue light, so it's not very much UV sensitivity. So generally, normal sunscreens don't have any effect because those block UV light, which isn't what causes symptoms in EPP. Zinc oxide sunscreens and some of the more mineral light blocking sunscreens should have some effect based on the spectrum of light that it blocks. However, I haven't talked to very many patients who think that it works very well, if at all. So it's potential that it has some slight effect, but there's not good data on it. And I also have heard of patients who think that it worsens symptoms. And it's hard to say that that is or is not true either, because there isn't good data on it. There have been different studies where they basically test different light doses on patients with different types of creams. And with that, it does seem that some of the light blocking physical sunscreens may have some effect based on that data, but that isn't real world situations where people are out and in light, and it's really hard to have good answers for that question since there's not very much data. So I think in general, it's good to use sunscreen just for overall skin health and cancer prevention. So it's probably good to use sunscreen, especially zinc oxide sunscreens. But certainly if there's an EPP patient who thinks that it worsens symptoms, then it's hard to say that that's not true either. So I think we have to have more research on the topic. But I myself use zinc oxide sunscreens just for the overall skin benefit. Hard to say if it really affects EPP symptoms from my experience.
Yeah, thank you. Excellent response. And as we know, a lot of times the responses are, we need more research. Right? So, okay, so the next question. This is about all porphyrias and mutations, so really a kind of a penetrance question. If there is any mutation in a porphyria gene, does that mean you could have porphyria or you do have porphyria?
So the different types of porphyria are different in terms of the inheritance and how many mutations you need for different types of porphyria. So I'll start with the acute porphyrias, and those are what's called dominant. So you essentially just need one mutation to have symptoms, but it's also has what's called decreased penetrance. So even if you have a mutation, doesn't mean that you'll ever have any symptoms. So with the acute porphyrias, if you do have one pathogenic mutation, then you are at risk for symptoms. There's a lot of research being done on which patients are higher risk and what other genetic environmental factors are at play, because there's probably many things that are affecting the risk of active disease that we don't fully understand. So we're trying to figure that out. But one mutation for acute porphyria does mean that you are at risk. For EPP, you need two mutations. You need one strong rare mutation from one parent, and then one very common mutation from the other parent. And that common mutation is in 10% of Caucasians and 50% of East Asians. It's very common. So you need, if you have both of those mutations in combination in EPP, based on the information we have, it's considered complete penetrance as far as we know, which means that if you have the right combination of mutations, you'll have some symptoms. Some people are more severe than others. And then in other types of porphyria, there's other types of porphyria such as CEP that's recessive. So you need two rare mutations, one from each parent, to have symptoms. So depending on the type of porphyria, one mutation isn't enough. For the acute porphyrias, it is enough, but there's other things that we don't understand about why some people have symptoms in that setting and others don't.
Great, thank you. Okay, this next question, well, first I have to go back to, you mentioned CEP, so we do have a CEP question, and the question is, will we ever get treatment for CEP? Valid question.
That's a good question. So CEP is, as many of you know, is a cutaneous porphyria that causes blistering and scarring and on sun-exposed skin, and it generally starts in infancy. And I am very hopeful that there will be treatment for CEP. File of Hyrox for CEP that will be starting hopefully in the US sometime soon. It stabilizes the enzyme for CEP and could help with CEP. Also, some of the clinical trials that are happening for EPP now could actually be helpful for CEP too. I'm actually very excited about it for other types of porphyria besides EPP, because for instance, bitopertin inhibits the uptake of glycine into red cells to decrease protoporphyrin, but I would expect that that would also help CEP patients too. And so I'm hopeful that some of the medications that could help CEP would be useful for EPP would be useful for CEP. So I think there's reasons to be optimistic for CEP treatments as well. There's less CEP patients and there's more clinical trials happening for EPP right now, but the benefit that we see in EPP could be useful for CEP and other porphyrias too. So I'm hopeful.
Great, thank you. Okay, so I'm moving back to another acute porphyria question, Amy, and this is from an individual who writes, I have a number of porphyria skirmishes, I think probably attacks or reactions. I have a number of porphyria skirmishes each month, intense attacks of nerve pain, shooting nerve pain in my legs, tummy, with pins and needles, and nausea. Is magnesium really helpful after an attack begins already? Is zinc in calcium pills totally safe for people who have acute porphyria? So magnesium and zinc and calcium pills, main question.
Okay. In terms of magnesium, zinc, calcium pills in acute porphyria, I don't think there's been any clear clinical trials of those supplements for acute porphyria. There are various supplements that I think could be helpful for acute porphyria, such as some of the B vitamins, such as vitamin B6 or folate. In the acute porphyrias, ALAS1 is one of the first enzymes of heme synthesis that is increased in activity in a lot of attacks of acute porphyria, and B6 is used in that enzyme reaction. And sometimes B6 can be low, and that could potentially lead homocysteine to be high, and in many patients with acute porphyria. So potentially that elevated homocysteine in other conditions can cause problems like chronic kidney disease and blood clots and other issues. We don't really know the role in acute porphyria, but I think in terms of supplements, I would be most interested in taking vitamin B6 and other B vitamins, since those B vitamins are involved in pathways that are related to heme synthesis, such as methionine and folate pathways, and some of those use heme and B6 as well. So those would be the supplements that I might think would have theoretically the most benefit for the acute porphyrias.
Okay, great, thank you. And for anyone who has joined a little bit late, please put your questions into the chat, and then I am asking Amy directly the questions from the chat so she can focus on responding. Okay, so the next two are people who would love to come see you. So I have two questions. The first is, my wife has AIP. She's actually in the ER. She is actually in the ER right now. My question is, do you see out-of-state patients virtually? And the next question is it possible to get to the clinic if you come from Europe? Can I pay to go there? So it is accessing the Porphyria clinic at Mass Gen.
Those are good questions. So some of the answers to this are related to medical licensing laws. So in terms of virtual visits in other states, I'm unfortunately not allowed to do virtual visits in other states because my medical license only covers Massachusetts. So it would be considered practicing medicine outside of my Massachusetts license. So I would essentially need to have a medical license in the state where the patient is before I'd be able to do a virtual visit for a patient in that other state, unfortunately. I can do, there's certain research visits I can do virtually, but there's limitations on, I can't give very specific medical recommendations individualized to that patient, can't essentially manage that patient, but I could potentially talk with that patient's primary care doctor, give some recommendations more informally in that setting, because porphyria is a rare disease. I think it is, sometimes helpful to, there are some ways I can give some help to people in other states, but not, I'm not really able to practice medicine in another state. But certainly if anyone wanted to come to Massachusetts for an in-person visit, that would be welcome for any patient. And then that would also allow me to have more freedom to help their primary care doctors or local doctors from more medical standpoint. Sometimes it's also hard for me to give very good recommendations if I don't have all the lab results and aren't able to do all the tests that I am interested in doing. So, but certainly welcome to come to Massachusetts for a visit here. In terms of European patients, similarly, I could see patients from Europe, but they would have to come to Massachusetts, and I don't know if the European insurance would cover those visits, but there certainly are, I'd be happy to see patients that come to Massachusetts from Europe.
Great, thank you. Okay. The next question, Dr. Dickey, is regarding AIP. And the question is, what is the correlation between issues with swallowing with AIP? So correlation with issues with swallowing and AIP. Are you aware of any?
So I am not aware of any very specific study on that. Certainly in AIP, there can be neuropathies, damage to nerves from acute porphyria, and there's a lot of nerves that are involved in swallowing. So I could, I have heard of also AIP being related to some gastroparesis, basically the issues with the stomach and motility of the nerves in that regard. But in terms of difficulty swallowing, I think it would be important to do like swallow studies and there's a lot of different things that can cause issues with swallowing besides porphyria as well. So I think it'd be good to do separate evaluations. I think for any type of rare disease, sometimes it's a lot of doctors attribute everything to that rare disease when it may or may not be related. So I think it's important for doctors to do due diligence and looking for all the other causes and do all the appropriate studies to help quantify things like swallowing difficulties in patients.
Great, thank you. Next question, we're flipping back to an EPP question, or erythropoietic protoporphyria. And this question starts with a statement: I'm anemic all the time. And the question is this common in EPP patients, please? And thank you.
Yes, it is actually common for EPP patients to be anemic. There's an increased incidence of anemia and iron deficiency in patients with EPP. It's generally not very severe anemia or iron deficiency. And also, EPP patients can be anemic and iron deficient from other causes besides EPP as well. Patients with EPP can have GI bleeding or other types of bleeding or other types of iron deficiencies. That's important for doctors to look for all those other causes of iron deficiency in people with EPP. In EPP, supplementing with iron is a bit tricky because giving iron will make the red cells make more red cells, and then there can be increases in protoporphyrin. So for patients that are very iron deficient, iron can be needed if people are bleeding or have very severe iron deficiency, but we just have to be very careful to give iron and also to make sure people really need it before giving iron. In some of the research that I've done on iron and anemia and EPP, even though some of the labs are low in patients, some of the markers of the body's iron deficiency isn't low or different, suggesting that even though the numbers might be low, it may be an artifact of whatever is happening in EPP and may not be true iron deficiency in terms of how the body experiences iron. So I don't know if that is a very clear answer, but I guess the answer is that yes, it is common, but we generally don't give iron supplements unless people are pretty low in terms of their iron and anemia, and just have to give iron carefully in that setting, monitor protoporphyrin levels.
Okay, great, thank you. All right, the next question regarding, and this is focused on all the porphyrias. Why are there such differing levels of severity in the porphyrias? We hear about patients who, in both acute and cutaneous patients, I'm expanding on the question, in both acute and porphyria patients, we hear varying levels of number of attacks in acute porphyria patients or amount of time that someone can be in the sun before they experience an attack in cutaneous. What's going on there?
A very good question. And it's a question that I'm actively involved in a lot of research to try to answer, but so it's true that in the acute porphyrias and the cutaneous porphyrias, there are some people that are very, very severe, some people that are not severe at all. And even within the same family, when there's the same mutation, there can be one person who's very severe and one person who's very mild. And that's true for the acute porphyrias, the cutaneous porphyrias. In the acute porphyrias, there can be people even in the same family, one who has very severe disease and one who doesn't even have any symptoms at all with the same mutation. And for all the porphyrias, there's likely a lot of things that are affecting the disease that we don't understand. In EPP, a couple of things that we know or think that has an impact is skin tone. So if one person has darker skin tone than the other, the increased melanin might be blocking the light to make that person more mild. Also, protoporphyrin level probably has some role. It's not the full story because I definitely know very severe patients that have lowish levels, but there seems to be some mild correlation between protoporphyrin level. That's the molecule that builds up in the blood that reacts to the light. Higher amounts probably leads to more symptoms. Probably iron status affects it. If you're a little bit iron deficient, it seems to make people a little bit less severe in terms of their light sensitivity. In the acute porphyrias, women tend to have are more likely to have active acute porphyria. About 80 to 90% of people with active disease are women because there's hormonal involvement in the attacks. The progesterone in the female cycle can induce attacks. But there's a lot of research being done to try to understand these questions. There's modifier studies for EPP and AIP happening now at the Porphyrias Consortium. There's an AIP modifier study that we're getting samples from families of AIP and trying to do genome sequencing to figure out what the reasons are that some people have disease and some people don't. With EPP, I've been doing a genetic modifier studies on families of EPP as well, getting samples from people in the same family, especially some people who have one person is more mild than the other, and doing genome sequencing to try to identify what's going on, because it's certainly a big issue and we don't have good answers to that. So hopefully sometime soon we'll be able to give more specific answers on why people have more symptoms than others.
And in doing the genetic modifier research, can you just share genetic modifier, just kind of break that down, what that means in plain language?
Yes. So in porphyria, we can often identify what mutation is causing the disease in the porphyria pathway. There can be, for instance, in EPP, it's ferritin is the enzyme. In AIP, it's HMBS or PBGD, the enzyme in the heme pathway that has a mutation that's the main cause of porphyria. But there's likely mutations or small variations in other pathways that are influencing why some people are more severe than others. Some of these mutations, like maybe there's like hemochromatosis that causes increased iron, or there's lots of very small mutations that have small effects in various genes that influence various diseases. And we have a poor understanding of what genetic differences might be affecting porphyria. So we're trying to find those differences. In some cases, it might be one mutation or one small difference in gene. In other cases, it may be a collection of small ones that are together influencing it, such as collections of genes that influence skin tone may be affecting EPP, or collections of genes that affect iron status might be affecting EPP. So trying to look into that more.
Terrific. Thank you for that further explanation. Okay, I have a Givlaari question. And the question is, my sister is, and for folks, this is an acute porphyria question. Givlaari is a FDA-approved treatment in approved porphyria. The question is, my sister is on Givlaari, which has been helpful, though she still has occasional partial attacks, mostly extreme confusion, high anxiety, and pronounced leg weakness. During these attacks, can hemin treatment be helpful?
That's a good question. And yes, hemin treatment can be helpful. So just to describe some of these treatments. So as I mentioned earlier, with the acute porphyrias, increased activity of one of the first enzymes in the pathway, ALAS1, can influence what the onset of attacks. And that enzyme, things like medications or stress and other things can influence that, and fasting can influence that enzyme. And most of the treatments for porphyria are aimed at inhibiting that enzyme. So hemin works by inhibiting that enzyme as a treatment, and givosiran also works to inhibit that enzyme, and generally used as preventative. So for people on givosiran, they get once a month injections to inhibit attacks, to prevent attacks from happening. But it doesn't completely get rid of attacks for patients. Generally, as people continue therapy, the attack rate tends to decrease over time, but people can still have attacks, and that should be treated with hemin as well. So they may need more inhibition of that ALAS enzyme to fully experience improved symptoms. So certainly givosiran and hemin can be used together, and hemin should be given in that setting for treatment of acute attacks.
Great. Thank you. I have a similar question, but different FDA-approved drug and different disease. Scenesse. So this is a patient that says, I'm on Scenesse and constantly get swelling on areas. I'm having an EPP reaction. Is there anything I can do to reduce the swelling or to prevent it?
That's a good question. So I have EPP myself, and I think that's a really big unmet need for EPP, is that a lot of the treatments that are being designed for EPP prevent symptoms like Scenesse. It causes increased skin tanning to block the light and to neutralize some of the effects of EPP reactions, but there's really no medication that we have that treats reactions once started, treats the pain or the swelling. And as an EPP patient myself, I can't tell you how much I wish we had a treatment that treated the pain or the swelling. In terms of the swelling, a lot of patients will use cold, or water, which can help symptoms, but I can't say I think it has any effect on the swelling itself. So unfortunately, I think cold might help. I don't think there's any good data for it. Actually, some people think that cold worsens the swelling or water worsens the swelling. It's hard to say one way or the other. So I really wish that there was some medication that helped the swelling itself, but hopefully in the future there'll be some better treatment for that.
Yes. Yes, we'll lead with optimism and hope. An EPP question, a follow-up EPP question, EPP XLP. I am low in vitamin D, and I've been trying to sit in the early morning sun. However, my skin has been blistering. Is the very, very early morning sun strong enough to give me the reaction?
So in terms of vitamin D deficiency, it is recommended to treat vitamin D deficiency in EPP with medications. Vitamin D medications are very easy to get over the counter, and there's high doses of it. I myself take 5,000 IU a day. Some of the doses are 1,000, 2,000, 5,000. You can also get 50,000 once a week to help. That's usually it needs to be a prescription that, to help build people up if they're really deficient. But there was a study recently that was published that looked at vitamin D levels in patients on Scenesse, and if Scenesse was good enough, because if people are on Scenesse, a lot of times they're in the sun a lot more, and actually Scenesse wasn't good enough to recover vitamin D levels in patients, and people really did need vitamin D medication supplementation. So even if you're able to be in the sun more, I wouldn't want people to risk EPP reactions and just be in the sun a lot to recover their vitamin D levels. I do think it's important to just take vitamin D pills. It's very easy in therapy.
Great, thank you. And I also just want to say once again that anyone who has recently joined, I see there's some people leaving and joining, please put your questions into the chat and I will read them aloud to Amy Dickey, who has joined us today. So I think you'll like this question. You'll know a lot about it. The question is, can you tell me more about Cimetidine and what it's supporting?
Okay. So I am leading a clinical trial of Cimetidine at MGH. And with Cimetidine, it's a very old medicine that was designed for gastric reflux that has very old data to suggest that it may inhibit ALAS, one of the first enzymes of heme synthesis. And there's been small case reports over time for EPP, AIP, PCT, all the Porphyrias, small case reports to suggest that there might be a benefit. A couple of years ago, there was an observational study in Europe that I think it was 18 or 20 patients that showed that there was a 20% decrease in protoporphyrin and improvements in light sensitivity in EPP. But there's never been any randomized clinical trial to show for sure if it does or it doesn't work. And it's also a medication that has a lot of safety data, so could be used even in very young children. As myself, an EPP patient, I remember having the worst issues as a kid, and so really wanting to figure out if there's any treatments that can be used for especially young children. So I'm doing a clinical trial at MGH where it's a randomized crossover trial to try to see if Cimetidine works. So 3 months of Cimetidine or placebo, 3-month washout, 3 months Cimetidine or placebo, and we're doing protoporphyrin measurements before and after each treatment period. And the last 2 months of each treatment period, we're doing light sensitivity measurements with light dosimeter, basically a watch that measures light dose over time in the blue, UV, red range every 2 minutes, and then also daily text message surveys to help quantify light symptoms and light exposure. So that clinical trial is ongoing. We're almost done with enrolling patients. So hopefully we'll have some data in the not too distant future about whether it works for EPP. It's a little bit too early for me to say for sure if it works, but that's the idea of the trial for Cimetidine.
Great. Thank you. Okay, I'm shifting back to, I have 2 or 3 acute porphyria questions. The first is, I have AIP and am concerned that my kidneys and liver may not be functioning at a normal level due to other health concerns. What are the best tests my doctor could run to find out?
Okay, and the question was liver and kidney, was that the question?
Yes, yeah,
okay.
AIP and concerning kidney and liver.
Okay, and so in acute porphyria, there have been studies to show that there can be chronic kidney disease in patients that is associated with acute porphyria. The best data on this is in the Scandinavian countries where there's a lot of AIP patients and comparisons to controls, and there is an increased risk of chronic kidney disease. And we're not sure exactly the mechanism. It may be partially related to mutation. PEP-T2 is a transporter that helps to transport ALA in the kidneys, and so there's essentially a genetic difference. About 50% has one type, 50% has another type in the population, and one genetic difference can increase the risk of kidney disease in AIP, so that may be part of the reason, or maybe some general inflammation that's from acute porphyria may be affecting the kidneys. But it is important in acute porphyria to be monitoring kidney function over time and see a kidney doctor if there's issues. There can be certain things seen on a kidney biopsy that would help to know if it's from acute porphyria or some other condition that can affect the kidneys. In terms of liver dysfunction, there has been observed some elevations in liver function in acute porphyria. The risk of liver disease in acute porphyria isn't, the liver disease isn't generally very severe in acute porphyria. For instance, in EPP, patients can have liver failure and sometimes need liver transplants from EPP, but generally with AIP, it's not the same type of liver disease and not as severe. And I haven't actually seen very good studies that even prove for sure that the liver issues in AIP is from AIP itself. So I think there needs to be more research to understand that liver dysfunction that's seen in some patients in AIP. But I think it's good for your doctor to follow those levels over time. And some things that might help is to also follow homocysteine, vitamin B6 levels, some of the B vitamins that I was talking about, because there has been in other conditions an association between homocysteine and chronic kidney disease, and homocysteine is known to be elevated some in AIP. So I think those would be good levels for your doctor to take a look at to see if you need supplementation of vitamin B6 or something like that. But it is important for doctors to follow creatinine, ALT, AST, and acute porphyria.
Great. Thank you. Another acute porphyria question. This is a big one. And the question is, what do you recommend for females that have monthly pain, nausea, anxiety, and insomnia due to changes in their hormone cycle? This person is looking for solutions to try something that is a little scarier to them, like lupron.
Okay. So in terms of women with recurrent symptoms during their periods, lupron has been tried, but I think givosiran is a better treatment in that situation to try first before lupron because of the side effect profile and the effectiveness of it. So if givosiran hasn't been tried, I think that would be a preferred treatment besides lupron, even if they're cyclic symptoms with periods, because givosiran can inhibit ALAS, decrease PBG ALA, even in that setting with people with monthly periods. Oh, wait, sorry, monthly attacks. And but then GnRH analogs is basically a medication that stops people from having menstrual cycles. And there can be a lot of risk from that, especially with long-term use, because if you give it for too long, it can cause osteoporosis and cause other side effects. Hormones are very important in the body for lots of different things for females. So you basically are causing people to go into menopause early, which can be very hard on people's bodies and cause a lot of issues. So I wouldn't use that as a first treatment for recurrent attacks, and would need to do it in a very carefully monitored setting for only a short period of time because of the side effects.
Great, thank you. I'm gonna switch, but I do have a follow-up question regarding cimetidine. So put your brain back in cimetidine mode. The question is, actually it's two parts. My daughter has been on cimetidine for 2 years to help support her liver failure. Do you feel this is a good option? And then when do you think a liver transplant should be considered?
So I would need probably more information about the specific case to answer the question very well. Cimetidine is generally a safe medication that hasn't been shown to have many negative effects on the liver, but there hasn't been any data to show that it has. I think there's been a couple of case reports of it being used in the setting of liver failure in EPP with some positive results that reported in papers, but there were only 1 or 2, 3 case reports. So it's hard to say anything very definitive about if it's effective in that situation. In terms of liver failure and EPP, that is a very significant, serious situation. So I think any patient with EPP and liver failure should be seen at a center that can do liver transplants and has EPP special experience in that situation, because some of the things with EPP, the liver failure in some situations can worsen really fast, and there's very specific treatments like plasmapheresis or hemin that generally are not used otherwise in EPP, that might be able to help decrease protoporphyrin level, temporize the situation. But for true liver failure in EPP, generally patients do need a liver transplant, but I would have to know more about the situation to give recommendations about that. But definitely do think that some specialized EPP and liver transplant care is important in that situation, and cimetidine generally isn't enough if it's true liver failure.
Great. And it was just posted in there that you can also contact info@porphyria.org to get connected with a liver specialist who is familiar with EPP. So thank you. We do have a question. It was I'm backing up a little. It was when cimetidine was the subject. Is there any similar data on famotidine, Famotidine.
Right. So famotidine is of a similar class of cimetidine as to the effect on gastric reflux. All the data that I'm aware of in EPP is about cimetidine, so it's hard to comment on famotidine. It might, since it's a similar class, it might have the same effect, but it may also not, because we don't know really why cimetidine might work, so it's hard to say if famotidine also has that effect. Famotidine is a more commonly used medicine now for gastric reflux because it has less interactions with other medications. Cimetidine has a bit more interactions with other medications, which is why it's a bit less commonly used. But the data in EPP has all been around cimetidine, so it's hard to comment to say if famotidine does or does not have the same effect. It may, but it may not. So yeah.
Understand. Okay, thank you. I've been trying to get to this question because it's an HCP, hereditary coproporphyria, and I want to make sure I get to all the types of porphyria. This question is regarding prednisone, and the person has lupus and HCP. Could prednisone counteract your cutaneous reaction to light exposure? If not, why? To follow up, I'm sorry, I have lupus and HCP, so skin is inflamed and steroids help that. So
steroids can be helpful in lupus because it's an autoimmune condition and it can help skin manifestations of lupus. In terms of the porphyrias, there is not data to suggest that it helps porphyria reactions. And the mechanism of injury in PCT, HCP, VP is or protoporphyrin accumulating the skin, and then the light being activating those porphyrins. So those porphyrins are, a lot of the porphyrins that are elevating the skin in those conditions are very light activated molecules, and then it damages the skin, causing the lesions that we see. But generally, actually, prednisone can inhibit wound healing, and that can be a big issue in those types of porphyrias. So I'd be more concerned that prednisone would hurt rather than help in HCP or PCT, because there can be chronic ulcerations and skin tearing, and prednisone can inhibit the effects of wound healing. And it's also, I know a lot of people, there was a comment about swelling before, a lot of people have tried it for swelling in EPP, and it definitely doesn't help swelling in EPP. From my own experience and other experiences, it doesn't have positive effects on porphyria and either EPP or probably HCP. So if the skin symptoms are from lupus, it certainly could be helpful for that, but probably not the HCP aspect of it.
okay, great, thank you. Okay, this next question, also acute intermittent porphyria. Hi, Dr. Dickey. In your opinion, what would be the best way to navigate suspected press or intracranial hypertension for a patient with AIP? Do you have any resources that we could read and share with a neurologist? And also, thank you so much.
Okay, so press is essentially an abnormality that can be seen on brain imaging, that it can be due to hypertension, and severe hypertension has been seen in acute porphyria. So it's basically an encephalopathy or essentially damage to the brain that's can be due to acute porphyria. In that situation, the way to diagnose it would be on imaging tests. So it is associated with acute porphyria, but it wouldn't be something to be managed as an outpatient at home. It would be something that if there is significant concern for press, to go to the ER and to make sure that certain brain imaging is done, and to make sure the doctor there knows that there's a risk for press in acute porphyria. Generally, it would be a neurologist or neuroimaging doctor that would diagnose it based on imaging findings on certain types of CAT scans of the brain. But yeah, it is a serious complication of AIP.
Right. Okay. Thank you. So this is a broader porphyria testing question. How common are false negatives in porphyria testing? Should I keep trying if there's a negative test and I don't have any other information on symptoms or type of porphyria that is suspected?
Yeah, so for the different types of porphyria, the issues with diagnosis are different. So for the acute porphyrias, if you have urine PVG testing that is done during an attack, that should be good enough for diagnosis. So if it's negative during an attack, then the abdominal pain is from something else. But a lot of times people may be getting the testing between attacks or other times, and it may be normal between attacks. Also, in variegate porphyria and hereditary coproporphyria, the urine PBG may not get quite as high as an AIP and may normalize a bit quicker. So sometimes it's more easy to miss in those conditions. So the timing of that can be an issue. So sometimes genetic testing can be helpful if it's hard to get sample at the right time, and but generally for people who have recurrent symptoms and chronic symptoms especially, the PBG may be high all the time. So if they're having significant abdominal pain and it's normal, then it'd be a sign to look for other causes, because there's so many other things that can cause abdominal pain. With EPP, the protoporphyrin is high all the time in EPP, but the issue can come up with if people send the test to the wrong lab. So LabCorp and Quest can't do the testing correctly. The testing that they call free erythrocyte protoporphyrin test is really a zinc protoporphyrin test that can be normal in EPP. So it's important to send the testing either to Mayo or UTMB or a lab that does it correctly. So that can be the main issue with EPP.
Okay. We are coming up on the top of the hour. May I keep you for 2 more questions?
Sure.
Okay. Thank you. The first question is in acute porphyria. This is a woman who's 36, has AIP, and has been on Givlaari and weekly preventative heme. And she still has almost daily pain and nausea. What other things can be done to treat these symptoms besides medication?
That's a hard question. So so givosiran, as we know, prevents symptoms, and then there can be prophylactic hemin. Sometimes in people have had good success from increasing the dose of givosiran. It's 2 mg per kilogram, but there have been some cases I've heard of using somewhat higher doses to inhibit ALAS more. Mentioned lupron or GnRH analogs, basically the medication to induce menopause to decrease symptoms, that can be tried at least for short periods of time. Generally, for people on GnRH analogs, you have to give back estrogen and progesterone eventually to help the bones. And so that can, symptoms can increase once giving back some of those treatments. But I think that would be something to try. Also, I've heard of some people trying, for chronic neuropathic symptoms, sometimes certain types of medications that treat neuropathic pain might be helpful. I've heard of that helping some in patients, but it may be helpful to see a pain specialist to get on the right regimen of pain medicines, whether for neuropathic pain or for opioids, to help manage those chronic symptoms. And also, sometimes people with acute porphyria could have some other causes of pain that may be contributing. Like I had a patient who had very significant lumbar back issues that were not the cause of the abdominal pain, but maybe contributing to some of the back pain that she had, and certain steroid injections and management of that was helpful for certain types of that pain. But in that situation, for people who are on givosiran and hemin, maybe also looking at any medications that the patient's on that might be causing symptoms, even if they're not in our database of medications that are causing symptoms. We don't have a lot of information. So sometimes taking away medications to see if it might be causing symptoms might could be helpful, or adjusting different lifestyle issues. So that's a hard question, though.
Yeah, it is. And then the last thing, another pain management question, and we'll have this be our final question. Then I have just a couple things to share, and we'll call it a day. But the question is, are there any studies, or is there any study for marijuana usage with pain management? I know this is an EPP question, but may want to answer it more in general. But marijuana usage with pain management.
There has been one survey study of marijuana use in EPP, and that study showed that patients have tried it, and some patients did think it was helpful. So I think it potentially could be used as treatment for pain. I'm a pulmonologist, so I definitely, not very pro smoking of anything, but there's, have been, people who have, tried it and said that can be helpful for certain types of symptom, but I would just be cautious on amount and wary of using too much of it. But there have been studies to suggest that some patients say that it's helpful. Yeah.
Okay, great. And with that, we're gonna just say thank you, Amy, for being here with us and rapid fire answering questions. We do have some more that we didn't quite get to, and we'll make sure we follow up with you. But what I really would also like to mention is that this, for everyone that is still here, that the Global Porphyria Day is coming up on May 18th. We are celebrating global porphyria along with countries around the world, and it's just important for physicians, healthcare professionals, the general public, patient community, to understand that porphyria exists and do what we can to further the diagnosis, the management, and the treatment of the porphyria. So Global Porphyria Day, and this is my ribbon, purple for porphyria. Glad to send this out to anyone who wants one. But just most of all, thank you, Amy. What we need, and help and responses from our physician community, and we're so grateful for all the work you do, and so appreciative of you for joining us this morning on a Saturday, or this afternoon, where everybody is, to answer all these questions. So everybody have a wonderful day, and thank you.
It's so great to be with all of you today. Thank you for letting me join you all.
Great. All right. Bye, everybody.